Okay, I'm going to go ahead and talk about tuberculosis. It's in your Williams and Hooper book, chapter 31. It's not the whole, it's just a snippet out of that chapter 31. I know we've already covered it, but I thought I'll just go ahead and do it. That way you'll have all the information. So, okay, so TB. As far as like the pathophysiology, tuberculosis is caused by the Mycobacterium tuberculosis. So it is a specific acid-fast bacillus that implants on the bronchioles or the alveoli down the bases of the lungs. And these tubercules kind of form down inside there that they can see on a chest x-ray. So one of the big things is to make sure that you kind of keep your immune system good and healthy, because the more healthy the immune system, the more ability it is to fight off any of these acid-fast bacillus that get into the lung tissue, such as people who smoke, people who have COPD, emphysema, pneumonia. They're going to be at greater risk for something like that because of the immune system isn't always in the best place. So only 5 to 10% of the people who come in contact with it are going to become infected. And it may activate or kind of change your immune system. So, okay, so risk factors. So what are some risk factors that somebody would have of getting tuberculosis? Well, someone who lives in a really crowded, poorly ventilated living conditions, such as high-rise apartments that maybe are sharing the same ventilation system. HIV patients, because we know that that affects their immune system. Immigration. So I don't mean immigration as someone who migrated maybe several years ago. I'm talking about immigrants that are coming in today's time that may have gotten it and are bringing it up with them, because they're all in very close quarters, they're all sleeping in the same areas, and they can pass that to one person to another. Chronic drug abuse, we know that that's going to lower their immune system. Alcohol abuse, elderly, because they have a decreased immune system. Crohn's disease, it's an autoimmune kind of immunosuppressant disorder, so that's going to cause that. People who take tuberculosis medications and they don't take the medication fully. They only take a certain amount. And when we get to medications, you'll see why people are not compliant with the medications. There is a vaccine available for tuberculosis, but we do not have it in our country. It's usually in more of your countries where there is more communal living, where that's passed a little bit more. If someone comes to our country that has the vaccine, they are not able to take the PPD because it will always test positive. So they have to do the quantiferon test, and that gives them the more accurate reading. Okay, so signs and symptoms. What are the things that we're going to see if somebody comes in and presents with tuberculosis? Well, one, they're going to have a cough because it's affecting the respiratory system. Sometimes they will have blood-tinged sputum because of those tuberculins in there aggravating that lung tissue. That's called hemoptysis. A lot of times they will have night sweats. Anorexia means lack of appetite, and weight loss. They will have a low-grade fever, so there's not going to be a 104 or something like that. It's going to be a low-grade fever like 100.4, 100, 100.6, the lower grade temperatures. Fatigue, dyspnea, chest pain. So a lot of your patients are going to come in presenting with the fatigue, low-grade fevers, and coughs that just are persistent and they can't get rid of them. So that's what they may present with. Diagnostic tests. As far as diagnostic, the PPD, which is the protein, purified protein derivative, that's your PPD. That's a skin test. That's the test that you're going to have to put under the skin. They do the right or the left. It's usually a two-step, so they'll do one arm, and then you get it read within 48 hours. And then you do the other one and you get it read within 48 hours. So that one is more of a screen. This test right here is more of a screening tool. So to see if someone's been exposed, to see if somebody has it, it's more screening. Just because you have a positive PPD doesn't always necessarily mean you have a TB. Sometimes you can have a positive from being on certain medications can cause a positive. So there's certain things that can happen that cause a positive that you don't have TB. But if you react to the PPD, then a lot of times we'll go ahead and do a chest x-ray. What we're looking for is those tuberculins in the lungs. Now, the most diagnostic way is the sputum culture. So the sputum culture is where they actually cough up the sputum and it actually has the acid fast bacillus in it, and they culture it and look at it and it has the acid fast bacillus in it. The other test is the QuantiFERON TB or the T-spot test. That is what's going to have to be done for those people who have gotten the vaccine. The QuantiFERON is a diagnostic test. However, it's very expensive. And so the PPD is the way that most people go ahead and get their TB. So thinking about your PPD, it is screening. So what they're going to do is put it under the arm, and you're going to get what they call an induration. An induration is like a bubble that occurs on the arm. And if it gets an induration within that 48 hours, and you actually have to run your hand over the arm to fill that induration. So it kind of looks like a blister or a bubble, or it might be red around there. If you have an induration, then that means that they're going to investigate further. If you have a 15 millimeter, which is a good size induration, and you have no risk factors, that would be a positive test. So if you don't get any induration at all, both 1-step and 2-step, then that's going to be a negative test. So just make sure you understand the difference between the indurations, when it has to be read. Just because you have a positive PPD doesn't necessarily mean that you have TB. So make sure you know those things. Therapeutic intervention. So now that you have TB, what are we going to do for it? Well, here's the reason a lot of patients are not compliant. The medication is a regimen that you have to take with multiple medications, and you have to take it for 6 to 24 months. So you could see that compliance is going to be a difficult thing for a lot of these patients. They may not be able to get their medication. Maybe they don't have prescription coverage. So a lot of times we'll have to get social service involved and make sure that they are completing their regimen, making sure that they're taking their medication, making sure we're getting it from the pharmacy. So there's a lot of things that are going to come to play here. So one of the medications is called INH. The other one is rifampin, pyrazinamide, ethubutol. There's 4 of these, and they have lots and lots of side effects. We're not going to go into the side effects because that's something that you'll get in pharmacology, but there's a lot of side effects to these medications. So a lot of patients will start taking them, get the side effects, or, I forgot to refill my medication, not take it for 3 or 4 months. So teaching and education is going to be a big part of the therapeutic intervention for your TB patients. A lot of it's going to be supportive care. So we're going to support, we're going to help them with their oxygenation. We're going to help them with the cough. We're going to help them with the fatigue. We're going to do all those kinds of things. Sometimes we can go in and surgically remove some of the tuberculins, and they're going to be in isolation. Which kind? Airborne. So you're going to have your tier 1 PPE. So your tier 1 is going to be standard precaution. So gown, glove, mask, all of that. And then tier 2, we're going to add your airborne isolation. So in tier 2, they have to be in a negative pressure room, and they have to have the N95 mask or the HEPA filter. So those are the additional things that they have to have on top of your tier 1 standard precaution. So what are we going to monitor? We're going to monitor their lung sound. So if they're in the hospital, we're going to make sure we're listening to their lungs. We're going to listen to their rate and their effort. Are they having difficulty breathing? Is their rate within the 12 to 20? Do they have dyspnea? Are they complaining of difficulty breathing? Make sure they're coughing up their sputum. We might have to call respiratory and get breathing treatments. They might have to have some lung physiology on their chest to break up some of those secretions. We're going to look at mental status. If they get too low of oxygenation, they start to get restless, decreased level of consciousness. And then we're going to look at peripheral capillary oxygen saturation, which is going to be your pulse ox. We can also do your ABG, so we can look at the arterial side, which is going to give us a very accurate reading. And then we're going to position them in a way that helps them to breathe. One is going to be Fowler's. We're going to set them up. Nobody breathes good laying down. So if you have one side that is more infected than the other, we're going to put the good side down. We're going to give them oxygen, either nasal cannula, however it's going to work for them. Teach them breathing exercises, and stop smoking if they're smoking. So those are some big things that we can do to help them. So we can give them fluids, deep deep breathing, we've already talked about that. Administer expectorants, turn every 2 hours, get them up and walk, and tell them to walk in their room. They're not going to be able to walk outside of the room because they're in isolation, but they can walk around their room. Many times your patients that have TB, they have a lot of dyspnea. So it may be a big step for them just to get out of bed and transfer to a bedside commode. And then maybe a few days later, they can do other things. A lot of these patients are going to go home with their TB, and they're going to have to do a lot of their things at home, a lot of their treatments at home. Suction PRN, it depends on, do they have a trach? Do they have an ET tube? Are they just a patient that can cough up their own secretions? So that depends on a lot of that. So we're going to monitor their response to treatment. So when you give somebody a treatment, you want to see how the treatment went. So after the treatment, you're going to look at their vital signs before treatment, during treatment, and after treatment. So you're going to look at your all your vital signs and your pulse oximetry. They may have to have portable oxygen all the time, so they may have to have oxygen on even at home all the time. Cluster your care so you can give them rest periods in between a lot of their stuff. Make sure you have a bedside commode, increase their activity very slowly, and sometimes we have to refer them to pulmonary rehab. This is not a disease that's going to be curable quickly. So this is a disease that they're going to go home with and they're going to deal with for 6 to 24 months. So it's something that we have to monitor and keep track of. So that is the end of your TB. So I'm going to go ahead and stop there.